Thank you for this amazing presentation. I wonder if exercise could be meaningful in your psychotherapy. I understood that cognitive behavior therapy has a role and planning, and I experienced with my own patients that sometimes exercise could bring endorphins, even if it's just just sitting on a home bike. But what I learned from the literature that sometimes patients who do exercise together, they also can profit, from that. I don't know if you have experience and then if you use that in children, because the literature is more about adults.
Yes, absolutely. That's an excellent point. So the answer to that is yes. And I think with children and adolescents, oftentimes we will interplay or interchange the idea of exercise with play, right? So play is a form of exercise for children and adolescents. And so oftentimes that will be part of a treatment plan. And when we're doing like traditional treatment, right? Behavioral activation is the primary modality for treatment of depression. And so behavioral activation essentially speaks to, we're going to have you do something even though you don't feel like doing it, right? We recognize that there are limitations in terms of fatigue, motivation. And so we just schedule it, right? And so each day you need to do XYZ. For example, you need to go play with your car in the driveway, or you need to go kick the soccer ball around for 5 times back and forth, right? So exercise does become a prescriptive part of treatment. Yes.
So maybe here we need to add one aspect, that we also had once I don't know, it's like, what was that? The UMDF also organizes these family sessions in the evenings, when we can talk about certain things. And I remember once we were invited, to talk about exercise and the effect on mitochondrial function. And I think that in individuals with mitochondrial disease, there is a very fine balance, you need to hit with exercise, because if you overdo it, it might actually do harm. And then if you don't do enough, it might not be good, to treat but it's true, because I just remember once when I had this discussion with psychiatrists in the Netherlands, then one of the psychiatrists told me that if I can get my depressed patients move, they would improve. So I think it's very true that it should happen, but I guess in individuals with mitochondrial disease, and maybe Amy can elaborate more on that, we have to really find a very fine balance, with this exercise and still maintaining the mitochondrial health, if you will.
Mm-hmm. Yeah, I mean, I can comment on that briefly. I mean, I think it's an excellent question, the role of exercise. And I think that there's no doubt that exercise can help improve mental health for sure. When we recommend exercise to our patients, though, we have people roll it out slowly and first under kind of supervision, right? We have them undergo physical therapy evaluation and then almost graded return to play, especially if somebody has not been exercising, to not do it on their own. Because if you do overdo it, right, we don't want anyone starting to exercise and then be in bed for the next 4 days or be too sore or too fatigued, because you can overdo it. And everybody's starting at their own individual level. And so you don't want to overdo it, right, as we've said. So, but I think that it can be incredibly helpful, not just physically, but also for mental health purposes. So I think we've valued this, not just for physical health, but for emotional health as well. So it's an excellent point.
And I think finally to that point, it's interesting, and I think makes a strong case for the collaboration of care professionals. And so making sure and advocating to have your mental health care provider, whether it's a psychologist or a mental health therapist, in communication with your medical team, right? So that individuals who are coming up with collaborative plans can indeed be collaborative in decision-making about what is most beneficial and least harmful for patients.
I was wondering, is there a link between autism and MELAS? I am diagnosed with MELAS. I have a 2.5-year-old granddaughter who was diagnosed with a neurodivergent or autism. and she's receiving occupational and speech therapy. And I had read somewhere or something that there's higher levels of autism in people with a mitochondrial disorder. She has not been genetically tested.
So there is a link between mitochondrial disease and autism. And I will just say that I have a very large number of children and I would say adults, it's a little harder to get a diagnosis of autism as an adult, right? But for children, there are children with mitochondrial disease who have autism for sure, right? It's part of the symptomatology. And I think that, again, people who have MELAS or the 3243 mutation, it may be more common. There are children also who have Lee syndrome who have autism. And again, I think of it as part of the symptoms. I think it's very important, especially for children who have symptoms of autism, to actually get a diagnosis of autism, because there are services that are available to children, right? It's also come to my attention through a few adults that I've seen that there are also benefits depending on what state you live in. If you're an adult with autism, there can be also additional services for adults. So for me, the most important part is if you have those symptoms, to be able to obtain the diagnosis so that you're then eligible for those services. Yeah. Yeah. There's absolutely a link. Yes. Yeah. Absolutely.
Maybe while the microphone gets there, I think you may ask the question, and I used to ask that question, that we talked about here: autism, depression, anxiety, maybe bipolar disorders, and many different psychiatric presentations in mitochondrial disease. But maybe Amy can tell me that if it's true what I'm saying now, that I don't think that there is an individual mitochondrial disease presenting with all of these. So that means that there has to be some additional factor that makes you more vulnerable for autism or depression. And I think with this really large databases that we're collecting now with the genetic, sort of diagnostics, so the exome sequencing, whole genome sequencing, we need to really dive into, these the individuals with a specific mitochondrial genetic problem, and look at if there are other genes which have been associated with autism, depression, or anxiety, are also have a variant. And then the two things, the interplay of the mitochondrial disease or the gene actually resulting in a mitochondrial disease, and then a risk gene for autism, depression, and they are together in that individual, will make that individual more vulnerable for depression. And I think now with the increasing databases, we can really dive into this and maybe really figure out the interaction between the genes, making you vulnerable for any of these psychiatric conditions.
Yeah, I'll just comment about that, because there's only so much information we can show in a short amount of time, but a lot of the literature, especially some of the older literature, goes into this, right? They're in any of our DNA, right? We all have individual changes, and some of the letter changes are not necessarily disease-causing mutations, but what we call these SNPs, right? These single nucleotide polymorphisms, things that are, again, not disease causing, but just a letter change. But some of these have been identified as risk factors for leading to depression, leading to anxiety. And in a lot of the literature that I reviewed, these have been identified as genes that can lead to risk factors for leading to mental health or leading to autism. And so, yes, if you have a mitochondrial disease and then you also have one of these SNPs, then that can lead to having more of a risk factor. So again, it isn't everybody who has a mitochondrial disease that might develop a mental health issue, but again, these additional genetic factors. And so that is one of the things that we're looking into. And then if you have a mitochondrial DNA disorder, the background that your mitochondrial DNA is, we call this the haplogroup, right? So some of you may know, if you have a mitochondrial DNA sequencing done, you may know what your haplogroup is, right? What the the letter is, like if you're haplogroup D or haplogroup H or what have you, sometimes that can also modify your disease, whether you have a more mild disease course or a more severe disease course. And that may also influence what your symptoms are going to be associated with your mitochondrial disorder. So these things, we're still learning all about the severity and what other associated symptoms you may have and the role of genetics in all of them. Mhm. Okay,
Hi.
next question.
So for a little bit of context, I am a 23-year-old, and I've been through college, 5 years, and then I'm going into my master's also. And I've been diagnosed with anxiety and depression for quite a few years, and genetically, like I don't have any confirmation yet for anything. I like to say I have my own thing probably. But we've asked a time or two to my geneticist about getting testing to see which psychological meds or other meds might be helpful. But he's always like, those are really more so for people who are like super severely need help, or like schizophrenia or these other things. But has there been more progress in finding genes that can tell you more about how, like different meds, like for anxiety and depression, the more common things? And if so, who would I ask for that testing?
So this is a great question, and I'll just repeat it in case anyone didn't hear it. So it's amazing how far we've come with genetic testing, right? Even in the last few years. And I don't want to create a situation during this meeting at this booth, but there's a company here called Variantix, which is now running whole genome sequencing clinically. And so it is a whole new world once again. So whole exome sequencing became clinically available several years ago, and now whole genome sequencing is clinically available. And when it first became available a year or two ago, it was amazing. And they just started doing, maybe in the last year, a new part of the testing that you can opt into, right? I don't know anyone here who's had this testing done, but usually when you sit down and you do counseling for these tests, one thing that they ask you to do, you get the counseling, we're going to look for any disease causing genes. The next thing you opt in or out of is, do you want any secondary findings? Right? So things that might not be related to your current symptoms, but risk factors for things like cancer or cardiac conditions, et cetera. Now, the new section is pharmacogenetics. That's what you're talking about. How do I respond to certain medications? And a whole section is devoted to antidepressants, anti-anxiety medicines, anti-epileptics. And so this is a whole section, and it must be 100 different medications. It's not just psychiatric medications. The psychiatrists have been doing these type of panels for at least 10 years, and insurances weren't paying for this when they started doing it. People were paying out of pocket for this. This is now part of whole genome sequencing that you can opt in or out of. And I would encourage you to stop by the Variantix booth if you want to hear more information about it. Now, my genetic counselors are not trained in how to talk to people about pharmacogenetics and how a psychiatrist may or may not be able to use that information clinically when helping to choose your medications. And so that's kind of like, well, now we have this information, but we want you to take that information back to your doctor and see how it's going to help them decide what medication to prescribe. But at least this information is now available. And when you do whole genome sequencing, you can opt in and at least have that information. And hopefully it's going to be very useful, especially if you've tried different medications and they haven't worked for you. Yeah, great question. It's called Variantix, and they have a booth here. Anything to add to that?
Yeah, I think that's.
This is probably sort of related to what she was saying. My son's 33. He had testing way back in the 90s that he had a complex 1 defect, and so mitochondrial disease has been his diagnosis, but nothing has ever been more specific than that. As he's gotten older, he never had a diagnosis of autism as a child, but he's become more and more autistic-like. He has cognitive limitations, physical limitations, kind of apraxia, where his brain doesn't tell his body what to do. very verbal, but the biggest problem in his life is his mental health at this point. The fact that he's oppositional, he doesn't seem to care about consequences. Like you can't say, well, if you do this, he says, well, consequences don't matter to me. So I guess what I wanted in coming here partly was to find out if other people are having this kind of experience as their children age, that they become more mentally ill. And then also what my psychiatrist is sort of at the end of her rope. He's taken every antidepressant and anti-anxiety medication, had a horrible reaction to Lexapro, which is ordinarily a normal thing, but he became violent and aggressive and we couldn't get him off it because he'd be more. So first of all, whether anyone else has had these kind of experiences or whether you see that. And then the other is you mentioned a list of meds that was available through UMDF for antidepressants as to what's better or worse for mito. Is that something I can get through UMDF?
I think we send them, and of course you have to use it with some caution, and then of course it does not actually, how would I say, advise, the psychiatrist. So you have to still talk to your psychiatrist or psychologist, and they might actually consider that, but I think there is also a protocol they follow. So this was just, as I said, we have to take it with a grain of salt because this was in animal studies. So we don't know if that really happens the same way in the human, but it might be, something that if you have a drug, it doesn't really help. Maybe you would like to try something different, which might be, a better and maybe improving the mitochondrial function. So that was just the suggestions that we made, but very carefully also said that at the end, the decision of the treatment protocol is on the psychiatrist and not basically what we said in that paper, because this was just an animal study and in vitro study. So,
okay.
but
Well, I
maybe
think
in
she's
that-
desperate for some information because she doesn't know what to do.
I'm going to say something. I know you have your hand up too, but I'm going to say something about medications. So, because again, I had a few other slides and I didn't want to go over my time. So there are long lists of medications that have been published on the internet over time, and a long list of medications to avoid. And we realized in the in the doctor community that many patients were avoiding medications that did not need to be avoided. And there was a paper that came out, I think in 2019, a group of experts went to Europe and they did what's called a Delphi criteria, meaning that we went through the literature, looked at all of the evidence, and a lot of it was from preclinical models, meaning you added the medication to either cell line or animals and saw what happened. And, a lot of medications are toxic to mitochondria. Mitochondria are originally bacteria. So you add antibiotics to bacteria, hopefully it kills the bacteria. That's what antibiotics are supposed to do. That does not mean that humans with mitochondrial disease should not take antibiotics. Okay, so there's a long list of medications that are toxic to mitochondria. And what we realized is our patients were being harmed by avoiding this list of medications. So when it was all said and done, this paper that came out, there's one medication to be avoided. And that is if you have whole G, you should not take Depakote. That is known. That is fact. There's another medication that if you have the mitochondrial mutation 1555, if you take an immunoglycoside antibiotic, you may have deafness because there's an immunoglycoside related deafness that can happen. Those are the two contraindications. Everything else is an individual decision, risk and benefit between you and your doctor. There's no other medications that are strictly contraindicated. I had a list of medications that I could show you how it is harmful to the mitochondria, and I could also show you how it might benefit the mitochondria. Same medications. I could go down an SSRI list and say, here's how it could be toxic, but here's how it could benefit. And so again, it's risk versus benefit, because every individual, whether they have a mitochondrial disease or not, some people don't tolerate Lexapro, some people do great on Lexapro. And it doesn't, so it's very, very individual. And so, so that's that piece. The medication piece, again, it has to be very individual. Yes, it's true that there are some patients with mitochondrial disease that are treatment resistant, but I think we could say that about many different disease states, right? That there's going to be a fraction of patients that have some treatment resistance. to these medications. They don't work for everybody. That's why there's so many of them. So that's number one. Number two, how old did you say your son is?
33.
23. So, I know you had your hand up. I don't know if you wanted to comment on the same thing. But I just want to kind of say my experience, and I'd love to hear if you have this experience. There are other, conditions, and I'm going to maybe name a few. And if Dr. Morava has some experience with this as well, I'd love to hear it. Non-mitochondrial diseases. And I've seen this happen in Down syndrome, in Angelman syndrome, and other conditions that should be what we call static encephalopathies, where children get to a certain age in this kind of early adulthood where they've been happy and pleasant and not having anger episodes. And again, this is like not early puberty, so you can't blame it on the testosterone surges and things like that, but they suddenly have these changes. And I've had a few of these children have to come into the hospital, and we're ruling out things like catatonia and other true psychological emergencies. And I've seen it happen, and I've had a few of my mitochondrial patients have to come in, and we're ruling out the same thing, where there's something very different going on, and it's in this early adult stage. I don't know if you've seen it in CDG or other inborn errors of metabolism, but I would, if it's a huge change at this age, I think that we have to rule out other conditions. Is there epilepsy going on? Is there something else, right, that needs more attention? And again, I'd love to hear your comment. I'd love to, hear from the other parent in the room, because I think that if there's a huge, a 180 shift in the behavior, we have to see if there is something else going on. Is there pain? Is there, something else critical that's going on that's causing a huge behavior change? Yeah.
And I will say it's just
and so every change I take as it could be totally independent, maybe related to the disease, but not taken.
And if you'd like, excuse me, to respond, I'd be happy to come on after you.
oh no, go ahead.
Okay, I was just going to say I agree and have had that experience also. I think in my practice, in much like my colleagues, if there's any big change in behavior, it is a time for reassessment, right? I don't want to assume that a progression and impairment is related to an already existing condition or diagnosis. We really want to look at it holistically. I think it's very challenging though, because there are situations where individuals experience decline as a part of their disease process. And it's tough to watch, it's tough to experience, and it's tough to try to manage, because it can seem like such a deviation from what you've experienced in the past. And so in those situations, oftentimes we need to kind of employ other levels of support. And I think it can be a hard change for patients and families when you're used to experiencing more independence or seeing your child be more independent in their care, to now having to problem solve and think through what are other ways that we can support their independent functioning, knowing that there are these kind of new areas of deficit that are impairing, and then sometimes can even feel dangerous, right? And it can feel very unsettling. And so I think talking through what are the options, what are the things that we can, how do we provide the least restrictive care, but also provide layers of safety that are necessary in order to have like good daily functioning, right? And so I think sometimes those higher levels of care, whether it, and it can be from employing other paraprofessionals, it can be looking at friends, family, how do we engage in a different way? And then what are, from the family perspective, what are the things that we can highlight and adjust in terms of potential triggers for behavior, right? Responses to behavior, to be able to manage the environment in a different way. So sometimes it comes from not so much changing the expression of the deficit, but changing how we manage the environment.
My son is going to be 26 at the end of next month. He was diagnosed in the year 2000 with a muscle biopsy. He has complex 3 mitochondrial disease. And probably over, maybe the last 6 months, we started noticing he was becoming more and more obsessive, higher anxiety. And our service and support administrator of all people recommended that we do a gene site testing. I don't know how they compare to what Varian ticks. It doesn't sound like gene site testing is just a mouth swab. And what we found was he's on Zoloft and he's on Risperdal. Those are both really good for his body, but he's also on Lamictal that he was prescribed for seizures, which I understand is also a mood stabilizer. And he's on 150 milligrams twice a day. And that ends up in the red column on his gene site testing. So they had to up his Lamictal. And then also part of that was a genotype, phenotype test, and his folate is non-existent. So they recommended and they prescribed Deplin. So I thought that was really interesting. I had never heard of that until when you said it, Dr. Goldstein, 10 minutes ago. So I'm really hoping this just started this week. So I'm really hoping that that would help. I don't know if that helps you at all, but I'd be happy to give you the information that I had, that I have my contact information, and maybe that's something that you could explore.
Just actually wanted to comment professionally on your question, because I do want to point out, again, we're talking so much from the medical perspective, but the age you're talking about is also the age where we see a lot of mental health conditions can also start. So usually around like 18 to those early 20s. So I think it's really important not just to consider, again, are we looking at the mitochondrial disease process, but making sure we are involving also that the mental health perspective, whether it's psychiatrist, psychologist, social worker, but really exploring that aspect in full too, because we don't want to assume it's the one when we're right smack at that age where it could happen.
Thanks, Jackie. That's an excellent point. Yeah.
Hi, my comment is almost in relation to hers. I'm the mito patient with complex 3 and LH and carrier, but my son doesn't have mito, but he has bipolar 2, rapid cycling in the brain, anxiety and panic attacks. He inherited that from his dad, who had bipolar, and my son started at a young age, 15. His father's suicide was the catalyst for him to get early. So I've been down the walkway of doctors in Cleveland, Akron, Canton. I'm from Youngstown, Ohio. And when she said about the swab, our psychologist had someone come to his office and they did a swab to find out what was a good med for my son to be on, because of me having a mito and not knowing about him and knowing what drugs fit him best. I can honestly say my son is now 29. He's in Connecticut, coming home tonight on being interviewed, going through job training. He left Chicago, didn't care for that job. He graduated summa cum laude from YSU, 4-point, and the struggles he went through, people don't understand mental illness. And he's not a mito patient, but my heart goes out to these parents. You have to be their advocate. If a door closes, you keep on going and going. I went from doctor to doctor till I got what I felt were the right answers, the right meds. My son was overdrugged with 7 meds, almost died Christmas Eve, 2015. I thought, no more. He got detoxed. We started all over. So it's up to the parent to make sure what is right, what is fitting, what doesn't sound right. But that DNA swab really helped my son. So again, he's not the mito, but I wanted to put my 2 cents in because I've been down that road and I'm still traveling that with my son. But there is hope at the end of the road. It's not always doom and gloom. And that's why I wanted to let you parents know, just keep on knocking on those doors and looking for the right answers.